Our next session is Innovation Promise versus Operational Reality. Please welcome to the stage our expert dragons, ready to hear from clinical entrepreneurs about their innovations.
So good afternoon and welcome to the penultimate session here at Confed. My name is Tony Young. I'm a urological consultant at Southend Hospital, Associate Medical Director in Mid and South Essex. My chair is in Innovation and Entrepreneurship at Anglia Ruskin University, but I'm also the National Clinical Lead for Innovation at NHS England. And we've designed a session for you this afternoon to kind of bring all the great things we've seen together across Expo around what we think are three really stunning innovations, but the problem we face as a system is about adopting and scaling them. So we're going to do this session in a Dragon's Den format, where in a moment I'm going to welcome our fiery, fearsome dragons to the stage who take the role of a medical director, chief operating officer, chief finance officer, and then a system leader. And our three intrepid entrepreneurs and innovators who are going to come and pitch are going to have to get past our dragons to get to an audience vote at the end to see if you would take their innovations up. Now, when I started at NHS England nearly 10 years ago now, I thought that at the time Simon Stevens and subsequently Amanda Pritchard had a lever in their office, and it was the lever of power, and they pulled it, and then everything in the NHS happened as a result. Now, it's really important that they do pull that lever and give blessing to the system, but what I've learned over the last 10 years is that actually the four dragons and their roles that we're going to have here today are absolutely crucial, and if one of them says no, then the system is going to take that innovation up. At the end, we're going to hear from Tim Ferris, our National Director for Transformation, who's going to draw together what we've learned from this session today and hopefully give you some words of encouragement and support to see how we can address this issue together. So first of all, I'd like to ask our dragons to come forward and join me on the stage, please. So, we expect our so I run the Clinical Entrepreneur Programme at NHS England, and Amanda Pritchard mentioned that yesterday in her speech. Over 1,000 frontline clinical staff now that we are helping grow and develop. Now, our dragons are actually all really nice people, but we've asked them to be dragons for this afternoon because we want to understand the operational reality of what's going on in the health service. So, we ask our innovators to pitch, and what I'm going to ask each of our dragons to do is they get 30 seconds, and I will stop them if they go over 30 seconds, to just introduce themselves. Some of them you will know, some of them you won't, and what their role is today and what they're going to be doing as that dragon. So if we start at the far end and work our way down, I have my mobile here. It's set for 30 seconds. It will bleep if you take too long.
Okay, I'm Victor Adibawali. I'm the chair of the NHS Confederation. I am a digital entrepreneur in my own right and a member of the House of Lords, but don't hold that against me.
Brilliant. And a great pitch, but what dragon are you, Victor?
Well, I'm interested in scalability.
So our system leader, interested in scaling and adoption. And that was a really quick pitch, so that's really good. Next.
Hello, everybody. My name is Charlotte Williams. I'm the Chief Strategy and Improvement Officer at Mid and South Essex NHS Foundation Trust. And today, Tony, I'm playing the role of a Chief Operating Officer. I believe I am standing in for David Sloman, so I know he would be wearing this dress and these shoes, so I feel like I'm doing really well. And I did do operations for 9 years, so hopefully I'll be able to plug back into that.
You can see how fierce they are, can't you? Already, it's just right. Okay, next, Nikki.
Good afternoon. My name's Nikki Stevenson. I'm a medical director, a deputy chief executive, and a consultant respiratory physician from Wirral. And today I actually will be a medical director, not just playing the part, asking the questions from a clinical perspective.
That's brilliant. Wow, these are all coming in really quick, these pitches. Henry.
Thanks, Tony. My name's Henry Black. I'm the Chief Finance Officer for North East London ICS. So my role today is to do exactly that, to be the CFO. Now, colleagues, I have some colleagues in the audience and they'll all attest that I'm a very supportive and enabling CFO. But today I'm going to be challenging, I'm going to be testing the efficiency, the viability and the affordability of the innovations.
Absolutely. Thank you so much. Wow, what an array of real talent coming from the front line in the NHS and what an experience too. So let's crack on. We're going to get our first innovator forward, which is Ash Calrier from Medishell. Ash, and I'm going to come to the podium, please. I'm going to give you 3 minutes for your pitch to the audience and to the dragons, and then I'm going to unleash them on you, okay?
Good afternoon. My name is Ash. I'm an orthopedic surgeon and I've worked in the NHS for 10 years. If I told you that hospitals need systems like Epic or Cerner to manage clinical data, you'd tell me, well, that's pretty obvious. But what about our non-clinical and operational data? It has a huge impact on patient care, yet is often neglected. And I'm going to prove that to you now. When I was a surgeon, I once cancelled 3 operations one morning because a light bulb in theatre was broken. Staff had known about it for days, but they hadn't reported it. And every day I'd be affected by similar issues. And if you're a clinician in the audience, you'll really resonate. This will resonate with you. Broken IT, your printer's not working, not having the right stock, equipment issues. These problems occur because our hospitals have too many help desks. We've got hundreds of suppliers. They all work in isolation. And the impact is really, really big. There was a study which showed the NHS had a 32% rise in cancelled procedures because of operational issues. That's why I founded MediShout. We're actually the first platform in the world which will aggregate all of your help desks and suppliers into one place. So that means we give clinical staff a one-stop app where you can report any operational issue, whether it's estates, facilities, IT, stock, equipment. The list goes on. And the beauty of MediShout is that once you've sent your report, you get real-time feedback, so you can track what's happening and therefore plan your patient care much better. So it's like having the Amazon or Deliveroo app in your pocket, but this time we've built it for hospitals. And we're also using AI now to predict issues in advance, such as faulty equipment. But what has our impact been? Well, we've got lots of publications, and I'm just going to mention 3 today. So number 1, cost efficiencies. Health economists have shown we can save NHS trusts £1 million per year in efficiency savings. Number 2, supporting our workforce. At one NHS trust in the east of England, we have 10,000 staff who have used MediShout. And number 3, we're reducing the backlog of care. We're doing this by partnering with medical equipment suppliers, such as Olympus, to improve the workflow in hospitals. For example, data shows when one endoscope breaks, we now save 4 hours of staff time and prevent cancelled operations and procedures. So there we have it. Just like hospitals need an Epic or a Cerner, hospitals also need a MediShout. We are tackling the biggest operational challenges in the NHS and are on course to be in 100 hospitals by the end of this year. So I'd like to thank Tony, the NHS Innovation Accelerator, and the SBRI for their support. And if you want to get in touch with me, my contact details are on the screen. Thank you very much.
Thank you, Ash. Well done.
That's very good.
Right, you did very well. Bang on 3 minutes. With orthopedic surgeon. Wasn't that a great pitch? Huh? We teach them to pitch on the Clinical Entrepreneur Programme. It's a real skill. Real skill. Right, straight to our dragons. I don't mind which order you go in, but we've got roughly 2 minutes each, and I don't want any fighting between either of you. Who would like to go first? I've started the clock on you, 8 minutes.
I'll go first. So thank you, Ash. I think that sounds as though it's got potential for helping staff time, but I'm not really hearing how this will improve patient experience and patient safety, because the example that you gave was just poor operational planning, and that was nothing to do with how that can be resolved by the app. So can you give us some data that would show that this does improve patient experience and patient outcomes, please?
Absolutely. Well, I think the first thing I'll say is, we have data which shows 97% of staff said we're giving them more time with patients. You're a clinician, so am I. I think we can agree that if you do have more time with patients, that is going to benefit patient care. The other thing around patient experience is we now actually put QR codes into hospitals so patients and visitors can report things. So if you're in a public toilet and there's a spillage, or there's not enough hand gel or not enough soap, which are infection control issues, our patient visitors can scan the QR code, which pings a message to the relevant person to come and make the environment much more safe and satisfactory. And then the final thing I'll mention on this is we won about £500,000 from SBRI last year to help reduce the backlog of care. And I would say for patients in the NHS, that's arguably the #1 priority right now, which is affecting how patients' satisfaction are, clinical outcomes. I think it's such a critical thing. And there's lots of things that we can't help with. So if your patient falls unwell the night before an operation and it needs to be cancelled, MediShout's not going to help with that, but we will make sure you've got the right equipment, the right facilities, the right stock, and we're now even being able to help to make sure you've got the right staff at the right time to make sure those procedures go ahead and they don't get cancelled. As I sort of mentioned in my pitch there, one study we've published shows, when an endoscope breaks, it has a massive impact on care. And it's not just the staff time that gets wasted, it's cancelled procedures. And by digitizing workflow, we're helping to improve that. So I'd say in terms of helping patient care, you're right, whilst we're primarily focused on making the systems and the staff more efficient, obviously the end goal is that they then provide better services to our patients.
Oh, go on really quickly.
So have you seen a reduction in health and safety incidents, for example, for some of the examples that you gave, saying that reporting spells?
And I want a quick answer from you, Van.
The answer is yes. We work with patient
Great,
advocates.
that's it. Yes, right. Next dragon. Who wants to go next? Come on. Yes.
I'll go next. Thank you, Ash. I think my challenge is, again, is about the data and the evidence. So I want you to convince me that this is relevant for the way that hospitals work now. You talked about the main issue that we have. We absolutely, definitely cancel far too many operations. But give me the actual evidence that says how many of those operations are cancelled because of failures of kit. Because as far as I'm concerned, it is 99%. Poor, as Nikki says, poor planning, not getting not having the workforce available. But the number of times that's actually because the light bulb has gone in the theatre, I'm not convinced.
So hang on. You're out of your dragon zone on that question, but I'll let him answer it quickly. And then I want a hard money question from you. All right, answer it quickly.
Okay, so I'm definitely not going to name a trust, but there's one NHS we know who cancelled 100 operations in a month last year because of equipment-related issues, sterile services issues, and not having the right stock at the right time. Those are challenges that we're directly solving. So it does have a really, really massive impact. Like I said, we're working with health economists at the moment to show how many extra operations are going to happen due to MediShout. It's predicted 5 to 10% within this particular region and hospital group. So I'll be able to give you the exact number later on this year.
Okay, so just to come back, Tony, the reason I ask is because cancelled operations cost us a fortune. So putting a number on that, I will need to know what is that number.
Yeah, so the minimum we've already looked at from the health economist is £300,000 per year, but I think the reality is it's going to be more because I think there's lots of knock-on effects that aren't included in that data.
Okay, thank you.
Good, you happy? Next, Charlotte.
Yeah, so Ash, sounds great, and obviously I'm all about getting through the backlog and making ops as slick as possible, but we already have help desks, and what we don't want is staff having to be like, oh God, I've got to log into another app because I've already got a stealth help desk, IT help desk. How are you going to persuade my colleagues in corporate services that this is the way forward, number one? And then secondly, how much IT time does this take? Because I'm waiting for backlog jobs in IT to get integrated to support my operational staff that are holding us up in terms of productivity. So I don't want this to be just another thing that isn't going to get done.
Yeah. So I think the purpose of MediShout is the fact we already have too many help desks and too many systems, but they all work in isolation. So we are that one-stop app, which is the front end for your staff, and we integrate with all the different back-end systems. So we're actually simplifying workflow for everybody that works in the front line. In terms of how that actually manifests itself and how difficult is it, we can now launch in really, really quick time. With one manufacturer, we've launched in 30 hospitals, endoscopy units, in the last 3 months, and each unit, on average, takes us 3 hours of staff time because there's no patient data, it's operational, and we've built the system by clinicians, such as myself. My co-founder was a doctor as well. We've got people in the audience who've worked in the company who've been clinicians as well. So we understand the healthcare system. We're partly owned by the NHS, so we've designed it around what the NHS needs and how we can be quick and scalable.
Good, you happy with that, Victor?
I've got 2 questions, actually. Why not just use Amazon?
Sorry?
Why not use Amazon? Because if they're any good, they're going to be watching you. And second is, actually, it sounds easy. It sounds really easy. But actually, getting people to change behaviours around apps is really hard, right? And most people have a phone full. How are you going to get it beyond the hospitals that you're in? Because if it's going to have any impact, this really has to scale. It has to scale nationally, UK-wide, frankly, for you to really make this happen. How are you going to do that? What are the I mean, yeah.
Yeah, I mean, it's a good question about Amazon and big tech. So we do partner with companies like Microsoft. We're on their accelerator. And the thing is, we can do things that big tech often can't is we can get onto the front line. We can look at the current workflows. We can work with staff and clinicians to make those changes. And like you said, behavior change is probably the biggest thing. The technology often comes secondary to the fact that you've got to change the way staff do things. And we're really good at that now because, as I said before, our core team are clinicians, so we already understand the problems in the front line. But then what you have to do is you have to work with the people on the front line. You can't just deploy technology and walk away. You've got to win hearts and minds before you deploy. You've got to make it customizable to the specific needs of the organization or the ward or the hospital. And then after you deploy, you have to be on site or you have to be available to train people and make sure it's working properly. But what we find is, once it's working well, we don't hear from our end users because they just love MediShell and it's just so intuitive and really simple to use.
So just come back. Oh, can I come back?
Yeah, please.
So,
quickly.
So it's both generic and bespoke. So you're saying that everybody can use it, but you work with individuals on the front line and you make it bespoke to their needs. That's a lot of work. That's a lot of scaling barriers. You think about the number of hospitals, the number of clinicians, the number of actual issues they each have. It might sound like 3 hours per, but that's a lot. When you multiply that, that's a lot. That's a scaling barrier.
Quickly,
Okay. What we find is the more hospital sites we're scaling into, the quicker and easier it's becoming. Because we're saying, oh, we've already done this process in this place or that place, so we're just going to copy and paste it and replicate it. And that's making it easier each time that we scale into new hospitals.
Your time is up, sir. I'm not going to let you carry on and answer any more. So you're going to be asked to vote at the end, and I want you to think about this. MediShell, a one-stop shop for all your help desks. I have seen no better champion for this than Yvonne, who is the housekeeper on one of the wards at Broomfield, who is your biggest champion, I think, with sending over 500 shouts of faults on the wall, beds that are broken, leaking taps, doors that don't work. They've run out of stock. And what she said was, I have to queue for the phone on the ward. I'm behind the consultants, the junior doctors, the nurses, the healthcare assistants. With MediShell, I'm front of the queue. I'm in front of the consultants. I love it, equitising that. Go and have a seat, sir. Really nice. Well done.
Nobody's going to do that for all the dragons. Nobody's going to do that for all the entrepreneurs.
Right. Okay, and I like it the way the dragons are having a go as me as well. That's fine in this role. But I'm a consultant urologist. If you're in front of me, don't have a go at me, I tell you. Right, that's not a good strategy, let me tell you. Right, Krish, you're up next. 3 minutes.
Thanks very much, Tony. Pleasure to be here. My name's Dr. Krish Ramdu. I'm the founder and CEO of Timber Health. I'm also another surgeon, an ENT surgeon by training. I've also done my PhD in hearing health and very privileged to have been in the first cohort of the NHS England Clinical Entrepreneur Programme. So what do we do at Timber Health? I set out to develop Timber Health to make ear and hearing healthcare more accessible for patients in community settings and utilising our workforce. When I was a clinical doctor, I was seeing so many patients waiting weeks on end to see me, and I was looking at the equipment I was using. I was seeing the staff who wanted to do more, could do more, and I was seeing that the pathway wasn't digital. So I set out on this journey to develop Timber Health, a ear and hearing health platform, a hardware and software solution that allows you to take the ear and hearing clinic out into the community. It allows you to do high definition otoscopy, removal of wax or infection, and do a hearing test. All of that is then pulled together into a digital record that can be shared with any specialist in any location. In the last 2.5 years, the solution has been used on more than 300,000 patients, and currently in the UK, we see 28,000 patients a month going through our Timper journey. We work with multiple partners. We're in 3 of the top 5 high street audiology practices, more than 100 different community pharmacy chains across the country, in opticians and care homes. And by building on that data, we've almost done it the other way around. And now we're now being commissioned by the NHS in Southwest London, where they have created their own Timper pathway. So if you were to ring up your GP in Southwest London, you would be routed into a Timper pathway into community pharmacies, provided there weren't any red flags, and assessed there and put into the right place at the right time. So do you need to go and actually see your GP? Do you need to go see ENT or audiology? We created some fantastic data. They've seen in the last 6 months more than 3,000 patients. 73% of them have been able to be treated in community pharmacy. Those 3,000 patients would have ordinarily gone for a GP appointment. We're now at a stage where we're ready to scale. We have got a health economic study, which is on for NICE approval. We were recently put in the board minutes of NHS last week by Tim Ferris's, and we're also launching in America. So for me, we're an NHS spin-out company and are really ready to hopefully scale within the NHS.
Brilliant, sir. You're 30 seconds under. That was very good. Bit more time. I want to start with a different dragon. Charlotte, should we start with you operationally first?
Yeah, thanks, Chris. I mean, again, it's all great, isn't it? It's always take demand out of the hospitals, shift it to primary care, release capacity in outpatients, but that's ridiculously difficult to do. You know, we've got staff doing extra clinics, trying to catch up, ENTs, you know, waiting times are huge. Where does the change capacity come on to support this? Because I don't hear anything from primary care about the fact they've got any slack in the system to take on services from the hospital. So do you support that? Do you help that change happen?
Absolutely. I mean, we know that there's a workforce issue, and I think if you look at the NHS long-term plan, it's how can we utilise other staff members? And as I said, you know, I was seeing other members of my team who could do more. So traditionally, this service has been in the hospital. We've then had it in primary care. They don't do that anymore. We've developed a training program which upskills HCAs, nurses, pharmacists, pharmacy technicians to deliver this service in a very strategic way, but also in a very safe way. We have the highest accredited training course across the country. And so for us, yes, they're taking busy time outside to obviously train up to be able to utilize the service, but actually that workforce want to do more. They want to deliver other services, and the fact that we've gone into those multiple sectors does allow us to scale.
And how much does it reduce demand on hospitals?
So prior to the pandemic, something like earwax removal was in the top 10 outpatient procedures. Now that is not even going to primary care. That's going to those allied services in pharmacy, opticians, and in community centres. Without
those patients coming back into the hospital afterwards?
Yes. So in the example that I said, they've delivered that now in community pharmacy. 73% of them were able to be treated and solved within community pharmacy. 6% were appropriately triaged to ENT. 4% went appropriately to ENT. The GP acts as the gatekeeper. They get a digital record which they can then share as their own referral platform.
Okay, I'm going to move us on. Nikki, medical director, you happy for this medical procedure to be taken out of ENT surgeons' hands? Is it safe? What do you think? What do you want to ask him? Come on.
Well, I think the innovation here is about the training and the pathways, and I'm not clear at all what the technology is adding, because if you put an oroscope in appropriately trained people's hands and set up a community pathway, surely that would be the same outcome.
It's the digital part of it. What Timper does, it does the digital otoscopy, so allows you to take that digital record of the ear. And then if there's wax or infection in the way, you can't see the eardrum, so it allows you to remove that. It then does a hearing assessment as well, and all of that comes together into digital records. So if you were sitting, as we have done, we've got another big pilot at UCLH, those ENT surgeons can see that information and appropriately say, yes, this person needs to come into the hospital or not. So yes, you could say an otoscope, but actually it's the bits around it which allow you to make an informed decision about where that patient needs to go. And I was sitting in my clinic, and we've done a study showing this. 40% of those patients didn't need to come and wait 16 weeks to come and see an ENT surgeon. We're closing that gap.
And back to Charlotte's point, what's your complication rate?
So the complication rate, we've been tracking that, so everything is recorded. So we have the safety measures in place. Actually, when you use the timper, you can't push it any further so that it touches the eardrum. On 70,000 patients that we had it with one of the big providers, they had a complication rate of less than 1%. Because those providers are taught not to go out of their scope.
And just what's the complication rate with the standard procedure, if you're less than 1% with yours?
So 3%.
3%. Okay. Good. Right, next. Henry.
Thanks, Tony. Krish, it sounds like a great product, but obviously you know what I'm going to ask. How is it going to save us money? So two linked questions, I guess. I want to know a bit more about the potential that this product has for really kind of, what is the scope in terms of early detection that then means that we avoid more complex procedures further down the line. But also, slightly unfairly, we've got no money, nobody's got any headroom, so it's got to pay itself back as well in years. So how do you get me to invest in this so that I know that it'll return and pay itself back in a year?
Absolutely. And yes, I think, so if we look at what we're solving for, ear and hearing health, hearing loss in itself is the single biggest modifiable risk factor for prevention of dementia. There's been a study that by 2030, because of the aging population, it's going to overtake diabetes and cataracts in the top 10 disease burdens. So there's definitely a downstream issue, 3 times more likely to have a fall with a hearing loss, and it's intrinsically linked to social isolation. So detecting it earlier is really important. So what we've done with Timper is it fixes 3 parts. Diagnostically, you can see the eardrum. So do they need to have an intervention? We can fast track when they need to do that. On the hearing side, because of the downstream issues, you can track when someone is progressively going down. Normally, it takes someone 5 to 7 years to do something about their hearing. If we're making it like an eye test, which you go and have every year, then you're able to look over time. We can prevent some of those downstream issues. So hopefully that covers some of the downstream issues and how we can support. On the finance side, yes, there's no money, but what we've done with Timper is look at it a little bit more holistically in the fact that you can see however many patients you want with a Timper system. So you can have one Timper system in a community pharmacy and serve that population. It's done that, frankly, it's just under £200 a month. The way that a normal referral would be for a GP into secondary care is normally £127 on average. And so I guess if you see more than 2 patients a month, you're hopefully solving for that as well.
Okay, and then give me some numbers for avoiding complex procedures further down the line then.
So
have you done any modelling about what, if you invest in this over 5 years, what it can?
And I need quick answers here because I want to move on.
Health economic study we've done. It's done externally. It's being published, and it shows that actually, if you adopted this with a new pathway across the system, there'd be £106 million of saving because of utilising a different workforce.
We'll get into the details later. Victor, I want to give you some.
No, it's very. I'm going to check myself out. Actually, I got a bit of going on.
Are you doing some free sessions afterwards?
Yeah,
there we have got one here.
I'll be straight down. It sounds very good and very slick. It's very great. I've seen a lot of businesses get to your level at great rate. Everybody raws about them, and then nothing. It's like they hit a barrier. And I don't know this. My hypothesis is they don't engage. There's something missing between what they can do in several regional examples and how that all fits together to make a national picture, even with the delight of Tim Ferriss backing you. So I'm wondering how you're gonna get over that, because people get very excited. It's great, whoa, big picture posters, and then literally nothing.
We need a quick answer. Come on.
Yeah, so I think it's with the evidence, the data. I think we did it a different way, showed some of the proof points in the private sector to show that it was safe, could be scaled. Now, some of the studies we have in place in Southwest London at UCL, I think the data proves that it actually has the ability to scale and be adopted and done in a safe way, and fits the bill of what we're looking for. Hopefully, an innovation to scale across the system.
I mean, I do. If data was the only requirement to get to national, then we'd have a lot of stuff that was. I mean, you know, the data is fantastic. I think it's a bit more than that. I think you could.
No, I think it's not. When I meant the data, I think it's we've ticked the boxes of workforce. How did the workforce deliver the service? What does the data actually show? Is it safe? And I think it's a holistic approach to data when I'm not just saying, we saved X number. It's a holistic
Okay, stop there. You've had enough time. So, look, I've taught you to pitch since I've known you, 7 or 8 years. Bring your device up on the stage next time and show them. It's the world's leading smartphone otoscope, in my opinion. And the story that I love is that one that was in the residential care home where the staff had been trained, the care staff, to look in the patient's ears, and they weren't routinely checked. And a daughter came along to her and had a mum. She'd had the Timber Health check on her ears, and she'd had her earwax removed. And the daughter said to her mum, she was just about to say goodbye, saw her every week, and she said to her, "Mum, I love you so much," and just squeezed her hand, and her mum burst into tears. It's a 90-year-old lady, just cried, and she said, What's wrong, Mum? Are you in pain? What's going on? She said, "That's the first time I've heard you say you love me in 2 years." That's what this technology does. Go and have a seat.
It's very impressive.
Right, last but by not least, Rachel Grimaldi. Rachel, do you want to step forward? Now, Rachel is amazing in so many ways. Anaesthetic registrar.
Very impressive.
Just on maternity leave at the moment, so you've stepped in, and thank you so much. Even though I think you're wonderful, you still just get 3 minutes. Okay. All right? I'll start when you start speaking.
Okay, thank you for having me today. Hello, I'm Dr. Rachel Grimaldi, co-founder and CEO of CardMedic, a senior anaesthetic reg currently on mat leave, and a fellow on the NHS Clinical Entrepreneur Programme and the Innovation Accelerator. CardMedic solves a problem that most of our clients didn't think they had a solution for before they met us. And healthcare inequalities cost the NHS billions, with communication issues at the point of care a major contributing factor. As many as 50% of patients experience communication barriers, such as language barriers, sensory impairment, cognitive impairment, literacy issues, and so on. And the outcomes of these patients are much worse, with increased morbidity and mortality, mental health issues, reduced compliance with medication, longer stays in hospitals, high rates of readmission, and so on, and ultimately poor outcomes for patients, staff, and healthcare systems, which are often avoidable. And furthermore, 30% of medical litigation is directly due to poor communication in healthcare. 69% of healthcare staff struggle to communicate with patients daily or weekly, and 89% feel current service provision is poor. This is not a new problem, but it is an expensive one. The traditional solution includes translators, interpreters, signers, speech-language therapists, and learning disability nurses, and indeed, these are the gold standard. But accessing these solutions can often introduce delays, they're expensive, and they lack economies of scale. And therefore, gaps in service provision happen regularly because achieving excellence assumes 24/7 availability of service, which is unaffordable, impractical, and logistically impossible in today's NHS. The shortfall, therefore, is often filled by friends and family, other staff members, or machine translation, which can be dangerous, unethical, and unfair. Currently unique, CardMedic fills this gap with an appropriate alternative. It's a multilingual library of pre-translated digital scripts that replicate common clinical conversations written by healthcare staff and allied healthcare professionals. They're available in 44 languages, easy read, read aloud, sign language videos, and an integrated translation tool. It's available as a mobile app and web app with over 1,000 scripts in all sorts of healthcare and allied healthcare settings as well. CardMedic has been available commercially for only just under 2 years, and we're already in 20 NHS trusts and 1 hospital in the US, and we're scaling across the NHS now and have had a 100% renewal rate so far. We've had huge uptake in maternity across the country, which is unsurprising given the recent Ockenden inquiries, and also in urgent and emergent care, neonatology and oncology. The Christie here in Manchester, for example, is a leading European cancer care centre, and we've done a case study with them that's demonstrated improved patient experience, reduced reliance on face-to-face interpreters, and improved medication safety. And lastly, we are aligned with national policy, particularly Core 20+5 and the Accessible Information Act. And we are highly affordable. We are a fixed price subscription, unlimited users on unlimited devices for unlimited amount of access. And in fact, our return on investment calculator demonstrates releasable savings in a matter of weeks from deployment. Thank you so much for the opportunity to present. My contact details are up there on the QR codes if you're interested in chatting more.
Brilliant, well done, and you came in just under time. So I'm going to go to our medical director, Nikki, first, because translation, it's got to be a quality of care issue for you. What do you want to ask, Rachel?
I mean, I can hear that you said that it improves patient experience, but what I'm interested in is patient safety and patient outcomes, because your product has got pre-written questions, and therefore we might inadvertently be asking the wrong questions of these patients, albeit that they're delighted to be spoken to in their language of choice. So what data have you got that shows that there aren't any negative impacts of your product? Or you can turn it the other way around and tell me all the positive, but it's the outcomes that I want from this, please.
Yeah, absolutely. That's a great question. So as you said, we are scripts where we have pre-written scripts that replicate common clinical conversations. They're all written by healthcare and allied healthcare professionals who've been practicing a long time. And they're designed to replicate standard conversations where it comes to taking a history, explaining a procedure, investigation, diagnosis, treatment, and so on. But of course, conversations get very nuanced, and we're not here to replace those existing services, but just to bridge those gaps in service provision. And we always advocate for using translators and interpreters for those nuanced conversations. So as you said, actually, we've not had any negative impact reported to us so far. It is difficult to measure health outcomes in terms of exactly how CardMedic might impact that patient's outcome at the end of a journey where they may have had many, many interactions from a communication perspective through their entire, say, hospital admission or GP attendance or interaction with the ambulance, for example, and CardMedic may not have been used for all of them. So it's always difficult to unpick exactly how CardMedic fits into that outcome. But we know that healthcare is a communication industry, and it's really important that we get it right first time when we're communicating with patients. So what we definitely look to do is measure how appropriate are we to use, and we work with our head of client engagement very closely. We have user groups with our staff and patients where they feedback regularly to us, and when we're rolling out, we have weekly meetings, then bi-weekly, then monthly, and we agree our KPIs and our outcomes that we want to achieve from that. We're working with 3 AHSNs at the moment, 2 of whom are working with existing clients to really assess the impact of how CardMedic improves that patient's safety and experience. One thing that we did look at was data.
Really
X's.
quick,
Okay.
finish it, really quick.
Yeah, we were looking at data X's, and could we reduce the incidence of data X's secondary to communication issues? But actually, NHS resources don't capture how many critical incidents are secondary to communication problems through data X's, but we know anecdotally that they are the root cause.
Mine does.
Go on. Do you want to? No, you're done. Good. Henry, what do you think of this?
Okay. So I'll ask my question in a sec, but just to tell you where I am. I think as a concept, I think this is absolutely brilliant. I'm the CFO from North East London. We're one of the most ethnically diverse populations in the country, and what is an ICS here for? It's to reduce health inequalities, and clearly communication is one of our biggest barriers. So I think the concept is brilliant, but tell me why your product is the best product available, and give me some numbers. If you want a business case to get through the board, give me some numbers as to what it's going to save.
Well, thank you so much. I'm glad to hear you say that, because North East London have just procured us, so that's fantastic to hear.
Don't say that and give it away.
Sorry. But yeah, absolutely. It is really important to get the numbers behind this right. And as I was saying before, that it is always difficult to pick out exactly how CardMedic could reduce health inequalities from picking out the actual financials of it all. But what's from the sort of the outcome perspective, sorry, can you repeat that, the question?
Well, I need to know
numbers, sorry,
if you're going to get a business case through the board, you've got to be able to. It's got to be able to stack up financially.
Yep. So we've done a return on investment calculator. Sorry, that's what I was going to say. So what we've looked at is releasing costs that are spent on translation services. So whilst we don't want to replace those services, there are definitely some conversations that could be had with patients that could be replaced using CardMedic. For example, we've got plenty of examples, but I'll give you one. Radiology. Explain to a patient that they need a CT scan and that they need a cannula for that scan. There is a hospital that we work with that previously they'd have to bring in an interpreter every single time they wanted to explain the need for a cannula and some contrast. And now they can use CardMedic instead. So with our ROI calculator, we are looking at if you just replace 10 phone calls a day across your entire ICS with using CardMedic instead, you can release those savings back to you in a matter of weeks from deployment. There are also qualitative aspects that we looked at as well, but we understand that
we wanted the numbers. That's
I want a number.
Yeah.
I'm going to move on. You didn't give him a number,
Oh,
did you?
about 180,000 on average.
180,000 per trust on average. Charlotte, in your operations role.
Yeah. I think this is great. I'm interested in thinking about the planned care pathway. quite often we have to cancel because patients haven't prepared appropriately. People don't understand what's required to go ahead. Last minute cancellations. So, have you got any information about that in terms of improving the access to plan care? And then, secondly, I suppose, it's another app-based thing. You've got to have an iPad. You've got to have the iPad available. How do you build it into a pathway so that it isn't people running around looking for the iPad so they can actually talk to somebody in the clinic?
Yeah, absolutely. I think, as you mentioned, access to planned care. So we're working with 5 ICSs currently and growing, and we have a lot of content for acute secondary care, and we are starting to build out our primary care library. We also work within our ambulance as well and have lots of ambulance services interested. But from a primary care perspective, we have a lot of GPs that are really interested in this platform because they have 10-minute appointment slots. It's really challenging to get translators there for exactly the time they need them. And then translating through a third party can be challenging as well, time-consuming, and so on. And we've actually done a study which shows that we're 5 times faster at accessing that content than a telephone translator for having that conversation. So we can really speed up efficiency in the primary care part. But we also have a huge uptake in urgent and emergent care as well, which I know that's not quite what you're asking, but from the unplanned care pathway, there's huge benefit. In terms of using us on various devices, since COVID, there are generally iPads quite easily accessible everywhere, but we're also accessible on mobile devices, desktops on wheels, computers, so we can be used in clinics. We have midwives that go out to hotels and use us to speak to refugees and asylum seekers, and so on. So we are really designed to be used on any device in any healthcare setting by any healthcare or allied healthcare professional.
Okay, I want to move us on. Victor.
It's really good, really, really slick. They're all really slick, aren't they? You trained them well, Tony. It's like listening to the Oscars. Anyway, but there's a couple of things. This could be what I sometimes call the help illusion paradox. In other words, people have got something that doesn't work. They get frustrated, particularly in poor areas. And so anybody that comes along with something that looks like it's going to make their life easier, I'll take it, right? And it works for a bit in the sense they will work with it for a bit because the alternative is where they were before, right? So that's the help bit. The illusion is that it is helping, but over time it turns out it really doesn't because you're putting translators out of work. You're putting translators out of work that might be from that local area. B, actually, people like talking to people. They actually like talking to people, particularly when they're in crisis. So you're cheesing them off. And thirdly, you're actually changing a process. No matter how good it is, you're actually changing a process. And you have to scale the changing of that process for thousands of interactions. I mean, like millions of interactions. How are you going to do it?
Yeah, that's a great question. We definitely don't see ourselves as putting translators out of work at all. In fact, as I said, we've really encouraged, those are the gold standard solutions. I've been practicing clinically for 17 years, where I work currently, or when I return from mat leave. 3/4 of the patients on my list, they and their families don't speak English as a first language, and I've had translators there twice in 6 months in person. So there are logistically challenges to getting translators and interpreters present, and we heard lots of stories about staff who actually speak
Come on, really quick.
Who speak that language, who know that the translation isn't fully accurate. So we're not replacing it, but we are bridging those gaps in service provision. When we launched, it was concept launch in 72 hours. It was while I was on mat leave with my third during COVID, and it scaled really rapidly because staff want us. We had global media coverage 3 weeks after launching, and the feedback we had from staff and patients across the world was, we need this, we want this. And the way we've grown our content library to over 1,000 scripts and growing is through members of staff getting in touch saying, we need this, please can we add our scripts, please can you add more languages, and so on. So it's grown organically for staff by staff.
How many people on your board are from ethnic minority communities and don't speak English?
We don't have anyone that doesn't speak English as a first language. We're still quite a young company. So yeah, we're growing our board at the moment. We've been commercial for less than 2 years at the moment. So we are starting to grow our board.
Okay, that's it. That's it. You're over time. So what we've got here is that first call, isn't it? Someone comes in. How can you communicate? And what Rachel didn't tell you, this came out of COVID. Patients who were ventilated and awake and couldn't communicate. So she wrote some phrases on a piece of paper, and guess what? The patient could start pointing to them and communicating and realizing the opportunity. And as for the nuances, I'm a urologist. I ask about 6 questions, and that's it. And there's only a certain number of answers. It would be brilliant in my specialty, but it's not going to work for everything. Go and have a seat. Well done. Right. Rachel, I think that's your phone. Don't leave that behind. Well done. Good. So now I think, are we coming to the vote now, or are we coming to, I think we're going to come to a vote, aren't we? Is there a question we're going to put up here now? Are we doing that? Hopefully that technology is going to work, and they're going to bring up a question. It's on Slido, isn't it, the question? Here it is in front of me. So for those of you who are on the Slido app, you can have a look at it. If you were a dragon and you could pick an innovation, I can see the results coming up here already. Maybe just one person's voted, which is why it's 100%. Which would you invest in? Would it be CardMedic? You heard Rachel last, didn't you? Would it be Timper Health? Or would it be MediShout? If you've got your phone and you've got the app and you want to vote, I can't see the actual numbers of people who are voting. We're just going to get a percentage of what goes forward. I'm going to leave that for a moment more. That was just the way it was set. You could vote for all three. It's pretty close. I have to. So, Tim, I'm going to leave that vote open, and I'm going to ask Tim Ferriss, our National Director for Transformation, to come to the stage and just draw this session together with his thoughts, and leave it to him if he wants to tell you the results of the vote that are on the screen in front of you. Tim.
Well, I'm just saying, Tony, I think they're all winners, right? Right? Are they all winners? Are they all winners? Okay. So I thought this was really fun, by the way. Tony, congratulations. So every Friday, I take a trip. It was actually an agreement I had when I first arrived a little over 2 years ago. And the point of my Fridays is to watch clinicians and managers delivering care and actually I was just recently visiting Tony's shop. And what I've noticed is that the innovation inside the NHS is absolutely astounding. And so, Tony, thank you for this event, and thank you to our innovators. They are demonstrating that even as you go out on the floor of the Confed and meet the vendors, you are and seeing the external innovation. This is commercial vendors selling into the NHS to try to solve our problems together in partnership. We also have the internal innovators changing it on the ground. This is the ecosystem, and it's important that there are these two different pathways to change. That's very important for the Transformation Directorate, because it's very important for me and my team to make sure that we are supporting both of those. And thank goodness we have Tony, and also thank goodness we have Victor, who is hosting the Confed. So thank you very much, Victor. So innovation comes from inside and outside. What you heard in actually these questions, the questions were brilliant, because you actually touched on what I think of as the core issues. The core issues are, it's cost effectiveness. Yes, actually showing cost effectiveness in healthcare isn't that difficult. I'm sorry to say it that way, but that's what I believe. Affordability is different. Okay, affordability is, and you mentioned it, thank you. Affordability is this year's budget. Do I have room in this year's budget or next year's budget? And the fact is, there are almost always, and actually several of you pointed this out, winners and losers. The vendors are always, the innovators are always focusing on the win. But if it is going to be cash releasing, there will be losers. By definition, something is not going to happen that is happening today. Now, interestingly, 2 of the 3 here today, they're actually, because the demand is so much greater than our supply. In fact, 2 of them avoided. There weren't really losers in that because of our mismatch in supply and demand. That's a great situation to be in. The second one is public procurement meets innovation. So I just have to say, public procurement processes, which are set in law, were not established for rapid cycle change. okay? They simply are two things that don't go well together. Public procurement processes assume a marketplace and competitors. None of those things, there's no marketplace for those things, right? So there's a problem in the relationship between innovation and public procurement that we have to overcome. And the third thing is risk. Our clinician, wonderful, thank you. We're always thinking about risk. And risk, I'll just say how the conversations go in reality is you get a group of people in a room, and at first there's always like, this is great, this innovation, it's going to help everything. And then one person says, well, what if this happened? You know, and you can always think of a scenario where there is some risk. And then the next person says, oh, I can do that even better. Like there's an even bigger risk. And then by the end of any discussion on any innovation, they're like, oh my goodness, this could cause global warming. I mean, that is sort of the way these conversations go. And so what is really important in all of these conversations where wonderful administrators are thinking about whether or not to invest is making sure that we understand the counterfactual, which is the risk of not changing, right? That's the risk that very rarely enters into these conversations. So I think there are 5 criteria for accelerating the adoption of innovation. And in my accounting that I just did from these presentations, all 3 of these meet all 5 criteria. So I'm going to list those criteria. I said them yesterday. It has to address a national priority. All of them pointed out the national priority. It has to decrease friction, primarily for patients, but also for providers. Like, I don't have to go through this. That's sort of obvious, right? It has to remove steps from pathways. So 2 of them clearly removed steps from pathways. One of them, it would be difficult to actually see the step. It facilitated steps and pathways, but didn't remove a step from pathway. And number 3 that I just mentioned, removing step from pathways, is tied to number 4. It has to be, you actually used the words perfectly, cash releasing in year. Listen to that, cash releasing in year. So there's a very important thing that happened last July when the Health and Social Care Act was passed and integrated delivery systems became statutory. And that is a big barrier to the adoption of innovation is the cost is borne in one group and the savings is in another, right? Integrated care systems mean actually they're in one place. They're on one budget. That is a big advance for innovation because it means that at the level of the ICS or ICB, transformation will always have both sides of the ledger on the same balance sheet. That is new in the NHS, and that should help accelerate transformation. So it needs to be cash releasing. And the last one also, you guys did a great job, is real-world evidence. So not randomized trial evidence, but in the real world, when it is operational, all 3 of them provided you with real-world evidence of this is on the ground working, this is the data we collected, and it is doing the job that we say it needs to be done, okay? Those are the 5 criteria. So in my book, all 5 of these are winners. All 5 of them meet these criteria, so all 5 of them should have accelerated adoption. And honestly, I am working with Steve Barclay, who just was on the stage earlier, about how we, in fact, make sure that innovation and the public procurement processes, which are right at the point of this beyond demonstration, but not able to be scaled, no marketplace, how do you make it work with our current rules around public procurement processes? Stay tuned. That is at the very top of Steve Barclay's list of to-dos, and we're working hard to address it. Actually, was working on a sub for him last night. So, on that very topic. So, that's my summary.
Thank you very much, Tim. That was wonderful. So look, the scores, it adds up to 108%. I don't know how the Confed computer system has got that right. I don't know where you bought that from, Victor, but I'd ask for a refund. And they're all in the mid-30s with about 4% between them. Yeah. So as Tim said, I think you're all amazing and all winners. I would like you to thank our fantastic frontline clinicians who've stood up and presented, and our fearsome, fiery dragons who put them through their paces. And I'm going to hand back to Victor to close the conference. So thank you very much to everyone.
Thank you. Thank you. Thank you. I'm just going to say a few words before everybody goes to catch their trains. Thank you. That was excellent. Dragons and all that stuff. It's all very good. Thank you, Tim. I agreed with every word that you were saying. Thank you, Tony, the prof. Thank you all for coming. Thank you all for staying. I just want to say a couple of things to thank our partners, our event partners. They genuinely are our partners, Accurix and Google, for allowing all this to happen. Actually funding it, pretty much, all of it. Can I just thank the best events team I have ever worked with? They are the best events team bar none. Bar none. The Confed events team, you are as slick as it comes. Can I also share that thanks with our partners in NHS England? It's not been easy. It really hasn't. You can imagine, doctor strike, rearranging who can come and who can't come because they're on the front line. So I want to thank NHS England as well for actually working with us on this, because it's been really, really challenging. As far as the content has been concerned, I started off by talking about challenging conversations. I hope you've had some. I hope you feel that you've got uncomfortable at times, and shared that discomfort. And as a result, got some answers, some solutions, some fresh thinking. I've actually had a few difficult conversations. I've got some bruises on my back, a couple of. But actually, that's what we were trying to do. I also thought you've had some inspiring conversations, some energizing events throughout the day. My favourite, and I'm biased, right? My favourite speech, as it were, here was Matthew's. I would say that, and I hired the guy. Right? I hired the guy. I'm sorry, but he did it without notes, right? He just stood it, did it without notes. Now, the key thing about that is not what he said. It's not about Matthew, right? So those of you that were in that speech, understand this. It's not about Matthew, not about me. It's about the Confed. So what he talked about was what the Confed stands for, right? We have a vision for the future of health and care in this country, right? And it's not even our vision. It's your vision. Right? We're a membership organisation. We're in the business of membership, right? So your business is our business. We don't say or do anything unless it's connected to what you want, what you say, and how you practice the delivery of healthcare to people outside this room. So for me, hearing Matthew speak clearly, with passion, about the need for a new relationship with the population around health and social care, the need to invert the pyramid, the need to understand how the centre can work with everyone else in a clear and transparent way. That's us. He just expressed it really, really well. Why? He's bloody clever, right? Which is why I got the job. That's why he got the job. And I should say, there was some rumours about, there were cards held up behind, he wasn't doing it without notes, he was doing it because there were cards. No, he did it without notes because he's passionate about it. We agree it. We are aligned behind it, and we hope you are. We hope you are. The future for us is about how we can work together. As I said right at the beginning, we cannot solve some of these problems on our own. We have to do it together, and we have to bring people into the room. So you've heard the Secretary of State for Health, you heard the Opposition Secretary of State for Health, you heard Amanda, you heard all the people that we need to keep talking to. You heard Richard Meddings, who, thank you, Richard, for staying and for carrying some of the load that Amanda couldn't carry. You heard all those people contribute to the debate, right? That debate has to continue, but we have to change the way we do things. We have to keep having those difficult conversations. We cannot afford to be comfortable because the really uncomfortable people aren't in this room. And finally, I always say this because it's just true, people get pessimistic about stuff because you're facing it and it's here and it's like really difficult and all that. And I just got to say this to you, and forgive me if you've heard me say this before, but I mean it because it's true. Everybody who's come to this conference, everybody is sitting in this room, and everybody who's going to get on the train on the way home and kiss their kids or their dog or the cat or whatever, you're all too lucky to be pessimistic. Can't afford it. Right? You have to be optimistic on behalf of everybody who isn't in this room. Right? And lastly, I'm confident in you. I rely on you as much as anything else, right? My family, my community, my people rely on you to get it right. So this conference was not a waste of anybody's time. You were here because we need to solve problems together. And I hope you've done that. I just want to thank you personally for taking the trouble to be here. Don't give up. This is the mission. It's all about what you do next. Leave better leaders. Have good journeys home. Thank you very much.